Hi, I'm Dr. Lori Burrows, and you're listening to Conversations, a podcast dedicated to raising awareness about antimicrobial resistance, otherwise known as AMR. AMR occurs when disease-causing microbes evolve to resist antibiotics and other similar medications, which is just about as bad as it sounds. That's why this episode proudly supports Antibiotic Awareness Week Canada in its mission to bring attention to these important issues. Welcome to the show. Today's guest is Dr. Jennifer Guthrie, an infectious disease researcher with Public Health Ontario. Like so many others, Dr. Guthrie's focus has turned towards COVID-19 this year, but she maintains a keen interest in tuberculosis and drug-resistant infections. Today, Dr. Guthrie is joining us to talk all things AMR, bringing to the show a wealth of public health perspective. Welcome, Dr. Guthrie. Can you give us a bit of background about your role as an infectious disease researcher with Public Health Ontario?
So infectious disease research in public health, particularly at this moment in time, is a very interesting place to be under the current pandemic. So at the moment, I would say nearly all the work, all the research being done is COVID related. I'm trying as much as possible to keep any non-COVID collaborations going. So for example, I'm working with Public Health England as part of a large consortium on tuberculosis antimicrobial resistance, and there's a master's student desperately trying to finish his thesis. But in non-COVID times, you can find me conducting research on a number of human pathogens of public health concern. So tuberculosis is a long-standing pathogen I've worked on for more than a decade. In the last few years, I've been working on methicillin-resistant Staph aureus. And so I'd say most of my research these days involves genomics. And so I use whole genome sequencing to understand transmission, outbreaks, sort of overall generally bacteria, but these days virus, population structure, and definitely I also work on antimicrobial resistance.
Okay, so why tuberculosis? What is your interest in that organism specifically, and how did you get there?
I got there in a bit of a roundabout way. I wouldn't say that I chose it per se initially to work on. Really, it was that they were working on a genotyping technique and wanted my assistance on it. And that was my first introduction to that. I quite quickly got Miru-Vinter, which is a method to differentiate strains, and it can help us with cluster investigations and things like that. We've now moved, many more than a decade later to whole genome sequencing. But really in starting that work, really have gotten quite passionate about tuberculosis. One of the things that drives my interest in infectious disease, and particularly tuberculosis, is I really feel quite passionate about making a positive impact. And TB is, well, yes, of course, is a very important human pathogen. It's also a disease that affects marginalized populations significantly. And I think generally the pathogens I'm most interested in have that component to it. I also have an epidemiology background, so I like to marry the microbiology genomic side with epidemiology. And to me, that's a pathogen that fits quite nicely into that.
So I know tuberculosis is continues to be a global problem. We've done a bit of work ourselves on sort of looking at candidate vaccine antigens. What would you say is the status of sort of multi-drug and extremely drug-resistant tuberculosis? Is this something in Canada that we worry about, or is this more of a global problem?
I'd say it's both. So luckily and somewhat surprisingly in Canada, we've had fairly minimal MDR introduction and XDR, extensively drug resistant. I think, to be honest, I'm not sure of the last count. I think it's about 6 cases of XDR, which is a bit surprising given the number of individuals that immigrate to Canada from endemic regions and from endemic drug-resistant regions. So there's a number of countries and regions in the world that have a lot of MDR. So a number of African countries. Peru has a lot of multi-drug resistant TB. Russia and former USSR countries like Ukraine, and we know Canada has the biggest Ukrainian population outside of Ukraine. And so we monitor for those, and luckily we definitely have some, but not a ton compared to those areas of the world. And multi-drug resistance is, a huge concern. Tuberculosis is a very difficult pathogen to treat, requiring multi-drug drugs usually in the beginning, and can last from 6 months to over a year. And if you have multi-drug resistant TB, sometimes multiple years.
Wow.
So it's not only very difficult on the patient, it's difficult on the healthcare system, and it's difficult for the individual who, obviously health-wise, but this is where it gets into socioeconomic status, and if individuals aren't able to work and they're also battling this disease, and it's a very expensive, obviously, to go through this type of treatment, both for the individual who may not be able to support their family in the way they normally do, and on the healthcare system as a whole. So it definitely is an issue globally as well as in Canada.
Yeah, I guess it's difficult to do things like DOT therapy, directly observed therapy, when you live in a very remote place or you are marginalized and maybe homeless and staying in shelters.
In TB, we have wonderful, wonderful field nurses and healthcare workers that actually, I know, so from my work in British Columbia, in Vancouver, and in Toronto, we have people that they know where to find people like you can't imagine, and bring a lot of incentives. What do you need? What can we help you with, as much as possible to ensure that people take their therapy and get better. In remote regions, they've really been working hard. I know in northern BC to implement like telemedicine, telehealth, to be able to help with DOT, because obviously that is a big issue. If you can't get to a hospital or a healthcare clinic, then obviously that means it's going to be challenging to take, and you have to take so much medication for such a long period of time. It's really difficult. And the northern territories, really, this is a big problem. Luckily, drug resistance is quite low in those areas, but treatment in general is quite difficult, and they often have to come to the sort of southern provinces for treatment. And obviously that comes with a whole host of challenges and expenses.
And I know there's no vaccine at the moment for tuberculosis. People are still using BCG. And I was actually interested to see that BCG is being considered as a therapeutic potentially for COVID.
Initially it was. I think pretty much they've scrapped that idea. I think the initial, my understanding of it, and this is, I wouldn't say I'm anyway an expert on this, my understanding was that there was some sort of, correlation is not causation. So correlation with countries that were doing well with COVID in the beginning, in the first wave, were also happen to be countries that give BCG. But again, correlation, not causation. And I think that they've pretty much ruled that out as a related, and it probably had more to do with other health region factors and things like that, because Canada's never widely given BCG, and compared to, say, our southern neighbors, we're not doing great, but we're doing better in terms of COVID.
Yes, we are, and I'm very grateful for that.
Yes.
Okay, so you've sort of described your job as CSI for infectious diseases. So given that we're here to talk about Antibiotic Awareness Week, what do the investigations that you and your colleagues do, how can they teach us about the future of antibiotic use?
So yes, CSI for infectious diseases, it much is like that in the work that I do around outbreaks and transmission. But because I do a lot of that with, obviously in a clinical laboratory setting and with whole genome sequencing, we're often able to use that same information from the genome sequencing to be able to understand antimicrobial resistance at a level that we, weren't able to before. So we can obviously use phenotypic testing in the laboratory, but now we're able to pair that with genotypic testing and investigate not only how it arises, and sometimes it can obviously be treatment failures for a number of reasons, or transmission, either say in a hospital setting for hospital-acquired infections, or for tuberculosis, say within a household, we've seen things like that. So it really, the type of work I'm doing and my colleagues do is really opening a lot of doors to understanding antimicrobial resistance in a lot of ways that perhaps we weren't able to before.
Mm-hmm. And when you look at outbreaks and strains, do you often see these being sporadic in Canada instead of, specific clonal complexes being a major problem and just popping up? I'm thinking of C. difficile in particular, right, where you have a lot of clonality. Do you see that with other pathogens when you're doing genomic epidemiology?
So we can. So I'll give an example for tuberculosis versus perhaps MRSA. So for tuberculosis, it's very phylogeographically related. So meaning that where you come from originally, or where you've lived a long period of your life, is generally speaking the strain you'll have, the lineage that you'll have. So for, say, a person's coming from Philippines, they often have a lineage that's sort of coined as Indo-Oceanic.
Mm-hmm.
But when you do whole genome sequencing, we see it's very diverse. But so it's clonal, I'd say, at a very high level. But we do see pockets in Canada of tuberculosis where it is, I would say, almost become endemic in some regions, often in, say, northern regions. I've done a study in Yukon territory where we had some interesting sort of off the beaten track regions that we could see has probably had a long history of that strain, which varies very little, that is circulating in that population, very small population. And that's probably because they just are physically, geographically separated from others. And so that's what circulates. MRSA actually published a study last year, or I guess earlier this year, all the same these days.
It's a blur.
It is a big blur. Yeah, I think it was in January. And so we do see clonal complexes of MRSA, and there's two, CC5 and CC8, that dominate. They used to be sort of distinguished between one was hospital acquired and one was usually more community acquired. There's a lot of intermixing of that these days, and it's not so straightforward. We can't say, oh, you have CC5, therefore you acquired it in hospital. But it's also shifting, and it'll be really interesting to see from a research perspective, of course, as how that's going to shift because of COVID restrictions. And those clonal complexes actually have different antimicrobial resistance patterns. So that could potentially shift that just by nature of how, society has changed the movement of people, as well as with mask use and more hand washing and things like that. So I think there will potentially be a ripple effect. In what way it will go, it's hard to say, I think, at this moment, but something.
Yeah, that's actually a great segue, because I'm interested in hearing, from a public health perspective, how do you expect that the pandemic is going to affect AMR? Is it going to decrease because of all the public health, the physical measures that we put in, or because people are getting sicker and getting prophylactic antibiotics when they're, ventilated and stuff? Is that going to impact?
So most people these days are actually thinking that it's going to increase AMR, because we know that, despite hand washing and mask use, obviously infections still happening, COVID's still spreading, so clearly it's happening. Obviously different pathogens are more touch related versus aerosols. And so it may change in that way, but our hospitals are still full. And no matter what infection control protocols are in place, obviously spread still happens. But my understanding, I haven't seen Canadian numbers on this, but I've seen US numbers, that anywhere from 75% to, I believe it was 92% of COVID cases are being prescribed antibiotics, which is obviously unnecessary given this virus. Even
mild cases?
I don't know about mild cases, but anybody with symptoms is my understanding. Okay. Again, wow. This is sort of new data that's floating around. And I think there's probably a couple of reasons for that. I think it's probably sometimes, particularly, again, this is coming out of the US and the delays in testing. So people don't know necessarily that it's COVID at the time of prescribing. They are coming in with a cough, they're sick, whatever. And so they're prescribing and there's a delay in diagnosis. So, you know, they're treating the patient. And I think there's a worry about co-infections. We know that there is a proportion of individuals, especially those that are in ICU or have pneumonia, quite ill, can get various co-infections. And so I think actually, despite, you know, the precautions that are being putting in place in terms of trying to have better infection control, some of the other practices may, at the very least, be a net neutral, if not increase antimicrobial resistance, especially if it's not even needed that they're being prescribed.
So as a public health infectious disease researcher, what's besides tuberculosis, which I know is your true love, what's the organism that really keeps you guys up at night? So if it was to become, you know, highly transmissible, multi-drug resistant, what would keep you awake at night?
I would say, and tuberculosis is my biggest fear. I would say also hospital-acquired infections like C. difficile is not one that I've particularly worked on, but my colleagues do. And it's called C. difficile for a reason. It is very difficult. And once a person has it, very, very difficult to get rid of. And so, and, you know, acquires drug resistance, and yeah, definitely challenging bug and something that's quite worrisome. Other than that, I would say obviously any sort of virus that's easily transmittable, like COVID or Zika, Ebola, those types of viruses are obviously quite worrisome. But at this point, they've stayed pretty geographically restricted.
So you mentioned that you also do some work on Staph aureus. That's always an organism that's fascinated me because it can pretty much infect any body part of any person, and it seems to be amazingly versatile. So what are you guys doing in terms of looking at Staph aureus epidemiology?
Yeah, so Staph, yes, as you mentioned, is a bit of a terrifying bug in that you can find it everywhere. And bloodstream infections are obviously a massive concern. I actually lost my maternal grandmother to sepsis due to MRSA. So I have my own personal stories. I've actually lost a number of family members related to infectious diseases that were resistant. So definitely, I understand the
motivation.
Yes, it really does. I think, you know, not that I didn't understand, and but it definitely hits home when it happens, and the helplessness I think that you feel, even as someone who understands so deeply what is happening. I also had a younger brother with cystic fibrosis who developed a resistant Pseudomonas infection and died as a result of that. So I think it drives a lot of what I do, I think, in part, but also that I understand how difficult antimicrobial resistance is, because when they're out of drugs, they're out of drugs. They're really, I think, you know, even knowing that, you often feel that, oh, they'll figure out something, you know.
We're trying.
Are magicians. Yeah, exactly. We're all trying. And I think MRSA in particular, so I work, so part of the work that I've been doing in the last few years is with the Canadian, Canadian CNIS, nosocomial infectious disease surveillance. So as part of CNISP, the Sentinel hospitals collect isolates of MRSA. And one of the things that now we're taking it to the next level, where they had done genotypic work, and now we're able to do whole genome sequencing, and really pair that with the epidemiology and understand how it's spreading and where it's spreading and who's more likely to develop serious infections from it, what's different about the bug in this case or about the individual. And so I think CNISP moving and in the direction of being able to use this newer technology to pair with what they're currently doing for hospital-acquired infections really will help us understand MRSA better, and hopefully be able to inform policy and practice to make some changes to improve things.
Yeah, Pseudomonas is the organism that's one of my favorites because that's what my lab works on. And it is a really difficult organism because, you know, we don't have a vaccine for that either. And it's because it's an opportunistic pathogen, it's, you know, the question becomes, well, who exactly would you vaccinate? Because, you know,
Yes.
cystic
Yes,
fibrosis patients,
patients.
of course, are logical, but you know, your average ventilated patient wouldn't necessarily be pre-immunized for Pseudomonas. So
No, yeah, it obviously a major problem, and I have a lot of experience on a personal level with it from my brother having had CF. So
yeah, it's a challenging bacterium, that's for sure. Okay, so you know, obviously a lot needs to change regarding antibiotic use at the research and development level and the policy level. What are some steps that you think the public can take to help mitigate antimicrobial resistance?
I think probably the first is for all of us to avoid as much as possible acquiring these infections that may require antibiotics. So good hand hygiene is one of the easiest things that public can do. Washing produce to prevent foodborne illnesses that might require antibiotics at some point, and keeping up to date, of course, with vaccinations where vaccines are available. But of course, this is not going to prevent all infections. We know this. But I think probably as a public person, having taken all those steps, if you still require antibiotics, to really ensure that you're following the instructions of the healthcare provider. To ensure that you take them as prescribed, don't take old antibiotics, take, you know, what's been prescribed to you currently and to you personally. I think those are probably the most straightforward things that people are able to do to help with resistance.
And one of the things that I've been saying about this pandemic, you know, as painful and horrible as it is, it's one of those catalyzing events that causes people to change the way they do things and change the way they think about things, right? So we've been trying to educate people about AMR for a long time, and it just, you know, it's been an uphill struggle. But you know, this pandemic has shown people, I guess, the value of being prepared for infectious diseases for which we don't have any vaccines or drugs. So what do you see as the upside of the pandemic as far as it relates to antimicrobial resistance?
I think I'm actually quite optimistic that COVID-19 has put infectious disease at the forefront of people's minds. I think it's what everybody talks about all day, every day, pretty much. Obviously, it's impacting everybody's life. But also how devastating an infectious disease can be. I think in Canada particularly, we really feel that we're safe from infectious diseases. They'll treat us with antibiotics and I'll be fine. People don't really die from antibiotic resistant infections. And so I think when a pandemic like this happens and people really see that, you know, healthy people can get quite ill, and unfortunately some do die. It's not just older individuals. And so I think it really puts infectious disease at the forefront. And perhaps this is a really good opportunity for people who work on AMR, who are very passionate about what we do and generally quite keen on science communication. And perhaps this is a good moment to seize the day and get the message out that, you know, infectious diseases are present, they are serious, antimicrobial resistance is present, and if we don't use our antibiotics wisely, we will be basically in this type of situation where there is nothing but staying home and wearing masks that you can do to really to mitigate that. And so I'm hoping that people perhaps will be sort of more aware than they ever have been of the impact of infectious disease.
What do you think the role of public health is in helping advocate for the government to change their policies in terms of, you know, approving tests for antimicrobial resistant organisms, or approving diagnostics, approving new drugs?
Yeah, I think public health has a large role to play there, and obviously a clinical laboratory has a large role to play. A lot of the sort of surveillance and research studies that we do are very often applied for exactly that reason, to be able to provide information on what policies are working, what things like, yes, okay, so say a long-term care facility that we've done a study on related to COVID, as soon as masks were implemented and full PPE, we didn't see any new infections in staff.
Mm-hmm.
So I think public health, in working with the clinical lab, and we did genomics on that to inform that, really can play a role in saying, see, you know, here are the numbers, this is what decreases or this is what changes. And I think governments are quite willing, if you provide them the evidence, to change things. Obviously, that's what they're there for. But obviously, we need the research and the surveillance to go into those things to be able to provide that information.
And can you tell me, so what, sort of give me a perspective on, you know, what was Jen working on last fall at this time that has been completely submerged under COVID, but that you would still love to resurrect once this goes away?
Well, funny enough, antimicrobial resistance, MRSA, was last fall what I was working on. That is sitting tight at the moment. So one of the things that genotypic resistance doesn't always predict phenotypic resistance perfectly. There's lots of mechanisms and mutations and things that we don't fully understand yet. And so there are a number of tools available, and what I was working on is pairing phenotypic data and genotypic data for MRSA in Ontario. And unfortunately, that is sitting tight at the moment, but it's there. And, you know, I every once in a while open some of my files and look at it, and then I get 100 phone calls about something else. So yeah, so it definitely is on my radar and will work its way back in for sure. It's quite an important project.
So you received a Killam Award a few years ago for some pretty fascinating work. Tell us about that.
So yes, a UBC Killam Award is quite a big, prestigious award that I was very grateful to receive and support my research. So through BC CDC, BC Centre for Disease Control, and UBC, I worked on a large study where tuberculosis samples collected over a 10-year period from all laboratory confirmed culture positive cases, so about 1,500 cases over that period that were whole genome sequenced. So using the results from the whole genome sequencing and also all the clinical data and epidemiological data, able to really understand how transmission occurred and what proportion, which is really important because you're kind of guessing. And again, if you want to inform policy and practice and implement new protocols, numbers are good. So if you can say, you know, 30%, 20%, 50%. So about a quarter of the cases in British Columbia of tuberculosis are acquired locally. About 75% are from people who acquired it, you know, potentially years ago. That's the interesting thing about tuberculosis, is it can lay dormant for decades, many years, but sometimes even decades. People may not even know that they were infected. And then sometime after they've arrived in Canada, maybe many years later, unknowingly they will reactivate and then require treatment. So about 25% were considered locally acquired infections. And then in looking at that, we could look at, so they've had some very large outbreaks, unfortunately, in British Columbia for a number of reasons. Largely in the biggest ones, generally in marginalized populations, the downtown east side, in Vancouver, and so on, as related to underhoused and homelessness, and some of it related to drug use and other housing situations. And so being able to understand how transmission is occurring and where transmission is occurring has been really important and really informative. And that work has actually been taken to the individuals responsible for the TB prevention and control in the province. So it's been quite informative work. As part of that, it also looked at clinical diagnostics and antimicrobial resistance prediction. Really interesting things came of that. So one thing is to be able to understand treatment failures where patients have a TB reoccurrence at a later date. Sometimes occurs months or years later, and with whole genome sequencing, be able to differentiate that better, and also see, was it because they acquired drug resistance and we perhaps didn't know? And very often when they have a reoccurrence, they've not been exposed again, that it's from their original infection, they've acquired drug resistance. You can then go back and look at their treatment regimen and see, in some of its older treatment regimens from many years ago, where perhaps things have changed now, we know more and use more drugs and different drugs. And so that was able to inform some of that, where there's a period perhaps that the treatment wasn't sufficient for a number of cases. And also be able to identify where transmission occurred. We did see a case of multidrugresistant TB where two parents had it. They had different infections, so they had acquired it independently. Both had reactivated and one of them had given it to the child, and we were able to trace that using whole genome sequencing.
Wow.
And then this data also is quite importantly, one of my collaborators is Oxford and Public Health England as part of the Cryptic Consortium, which is a very large global consortium, where we're looking at being able to replace phenotypic susceptibilities, which for tuberculosis are very tedious and long because it's such a slow growing bacteria. And so being able to replace that using whole genome sequencing, so that that data from that study has also gone into Cryptic Consortium, and I'm still involved in that collaboration and providing more genomes to that, and then working all together looking at predicting resistance that can help to guide treatment in coordination with the WHO as well.
So thinking of new drugs for tuberculosis, because it is sort of a problem that North Americans don't have highly visible to them, and trying to convince drug companies to make antibiotics is already challenging enough, but to get them to make antibiotics for something that they can't charge an arm and a leg for is even a bigger challenge, right? So do you see that this is a big problem for creating new drugs for tuberculosis in particular, as opposed to, some other bacterial pathogens that seem to be a little more highly visible?
It's something that we talk at nearly every tuberculosis conference, that it is one of the major issues, is that up until recently, in the last few years, we hadn't had new TB drugs in 50 years.
Wow.
So yes, there is a major issue. And a lot of it, there's lots of reasons. Obviously, tuberculosis is a very difficult bacteria in general anyways. And so for drugs to make it all the way through, and they're often really quite harsh because it is so difficult, a bug. So they don't always make it through clinical trials all the way, just because there's obviously side effects that are quite difficult to manage. And I think also, as you mentioned, one of the major issues is that where TB is endemic is also where people do not have the funds, either personally or their government, to be able to support at a large scale to pay for these antibiotics. And so obviously pharmaceutical companies, designing antimicrobial antibiotics and being able to carry them through clinical trials is a very lengthy, expensive process. And if they don't think that they will get paid for it in the end, obviously it's a very challenging thing to ask them to take on. I think this is where other organizations can step in and have stepped in, like Gates Foundation, to be able to support those efforts.
Yeah, I look at the warp speed efforts that are going on in the States to develop COVID vaccines, and I think, this is the perfect model for what we need for new antibiotics, right? So you just
if only.
you pay up front to get the product at the end, and that way the risk is lower.
Yes. Yeah, it's definitely something that those of us who spend a lot of time researching TB and TB resistance are quite not surprised, but just at the amount of global effort going into vaccine versus, we've been begging for for years and years and years to say, can we just get one new drug? So luckily we've had a couple new drugs in the last few years come online, but still, we still use isoniazid and rifampin are, the main two drugs used for TB, which have been long the main two drugs used for TB.
So the new drugs that have come online, are they prohibitively expensive, or are people using them for really recalcitrant cases of multi-drug-resistant TB?
Yeah, I think in most cases, I think cost-wise, it probably depends highly on where you are and the availability of them. There have been in the last few years, even in Canada, some shortages of just the standard first lines and second lines. So sometimes that is an issue, but I think in order to protect the drugs, they're really sticking, if you have just plain old TB, not resistant.
Run of the mill.
Because I know, run of the mill, boring old TB. Isoniazid, rifampin, ethametol, and PZA are the main drugs that are used in the first 6 months, and that they're quite effective when used properly in the right circumstances. Obviously, if people have, say, some of them cause issues with liver, and if someone has a liver issue, then you need to look at other alternatives. But so my understanding is at this point, the newer drugs are being used for particular cases.
Well, Jen, thank you for joining us, and thank you for fighting the good fight, saving the world from COVID.
Well, I don't know about saving the world from COVID, but trying to understand how it's spreading. We'll have some good stuff coming out this year on that for sure.
Oh, that's awesome. Well, good luck and great talking to you.
Thank you so much.